So thank you, Rajul and the Janta Group for this invite. You owe me because you woke me up at 5 a.m. on Saturday morning. So I hope this is worth it. It's really good to see friends across on a virtual forum like this, and good to be back in Mumbai, even though virtually. That's what I would say. So Rajul asked me to talk on the evidence for minimally invasive glaucoma surgery and what the future might hold a little bit. My slides should change, but they won't let me. Okay, here you go. So if you consider incisional glaucoma surgery today, a patient walks into your practice and you want to consider glaucoma surgery, these are your various options available to you. So it's really a plethora of, so you have a variety of glaucoma surgeries available to you. You have minimally invasive surgery, you have less invasive glaucoma surgery, you have traditional filtering surgery, and you also have cycloablative procedures. It is you and you alone as a surgeon who's got to decide what is best for the patient in a given scenario. And the patient will always be dictated by how you present the case forward to the patient. So yes, the patient does make the final decision, but you as the doctor does influence what decision the patient finally makes because of how you present the case to the patient. So trabeculectomy, we're all very well versed of. We've known it for the last 60 years, lots of modifications. In its present iteration, we use a lot of mitomycin, but however, the success is still limited by scarring, hypotony, and infection. Even the other day, we saw a patient of late bleb-related endophthalmitis. Because of use of mitomycin or the way we fashioned our blebs in the past, or whatever it may be, whenever you make a bleb, you are subjecting the patient to a long-term risk of bleb-related endophthalmitis, which is a blinding disease. So you got to rethink glaucoma surgery. So if you rethink glaucoma surgery, one of the first things that comes up is, can we use the functional part of a conventional outflow pathway, or can we enhance uveicular outflow? We have done this for donkey's years in kids, right? So, you treat congenital glaucoma with a trabeculotomy or a goniotomy, and we did that for many, many years. The question was, would this work in adult patients? So if you look at the way that conventional outflow works, you can see 60% goes through the conventional outflow, 40% is uveoscleral, and most of the resistance is at the juxtacanaliculair meshwork. So why does MIGS work? So MIGS procedures, we have about 15 to 20 years of evidence, or you can call at least experience using these procedures. And we know that typically lower the pressure into their mid-teens. And most patients probably still need some medication. You can never promise them that you'll be totally medication-free. It seems to work well in milder and moderate disease as compared to a severe disease, and the safety profile is better as well. They all work well with phacoemulsification because you're going through the same small incision. If the procedure fails, your conjunctiva is naive, and therefore you can still perform more aggressive filtering glaucoma surgery. The choice of the exact procedure is based on the surgeon and amongst other factors. So what are your outflow targets? You have Schlemm's canal, you have a supraciliary space, and you have subconjunctival space. So there are devices that you can implant. You can also do trabecular meshwork, destructive procedures, like the trabectome was one of the first MIGS procedures invented by George Barwell that I joined practice in Dallas in 2007, and that's when I first started doing MIGS. And the trabectome was my first machine that I used it on. Since then, there have been various iterations now. It's called Trabex. There's the Cahook goniotomy. In India, we have the bent needle. You bend a needle and do called the bank procedure. You have the GATT. You have viscodilation using a microcatheter. There's an omni viscodilation. So many devices. It's impossible to keep up in the market. Every day you turn around, there's a new device in the market. But what are they all doing? They're all essentially doing the same thing, that they are bypassing juxtatrabecular meshwork and getting the aqueous into Schlemm's canal. Going to the supraciliary space, we had the CyPass implant, which unfortunately got recalled due to endothelial cell loss over a 5-year period. Right now in the US, the only thing we have available is an alloflow spacer, which essentially are uveal spacers. They are collagen implants you put in the cycloidal space to sort of enlarge the cycloidal space. The MiniJect is available in Europe, I believe. The iStent Supra is still not available. It's still somewhere in trials. Now, should we even consider subconjunctival surgery as part of minimally invasive glaucoma surgery? That's a whole debate by itself. But I think if you go to most lectures, you hear most surgeons talk about that. They do include a small portion within MIGS. And we have a couple of devices. We have the Zen gel stent, 45 microns, and we have the pressure flow. Unfortunately, we don't have the pressure flow in the US, so I have no experience with that. So the Glaucoma eye stent was the first device that came out about 2011, 2012, implanted ab interno, created a big uproar, and I think they're aggressively marketing it now in India as well. That's my understanding. It was the first implant approved by the FDA for use in conjunction with cataract surgery, and was based on the evidence of this study, which essentially showed that if you take a proportion of patients, randomize them to cataract surgery alone or cataract surgery with the eye stent, at the end of a year, the patients who had cataract with the stent certainly did a whole lot better as compared to cataract alone. Any way you look at it, reduction from baseline intraocular pressure or just a base intraocular pressure less than 21, which are the darker bar curves. But I think what this study taught me more than anybody else is that cataract surgery alone also lowers intraocular pressure pretty significantly. But if you continue this data to about 2 to 3 years, what you found is little disparity or divergence in the curve, wherein the eye stent group seems to continue to do better, whereas the cataract surgery alone group seems to slowly elevate in intraocular pressure. There are various iterations now, and finally, we have the iStent inject, and right now we have the iStent Infinite in the US, which is they're actually recommending you implant 3 little collar stent implants in the eye. The Hydrus microstent is a big boy, made of nitinol, covers nearly a quadrant of your 360-degree meshwork. It's 8 millimeters long. Again, implanted ab interno through a clear corneal incision with a trimodal mechanism of action. Essentially, A, you're bypassing trabecular meshwork. B, you're dilating Schlemm's canal. And C, you have these little windows through which the aqueous transgresses through and gets into Schlemm's canal. And your coverage of the meshwork is over 90 degrees. So based on the Horizon trial, the Hydrus implant was approved in the United States. It's a prospective multi-center trial. Phaco alone versus Phaco Hydrus. Patients with mild to moderate glaucoma. And again, you're essentially looking for reduction of intraocular pressure and reduction in medications. And there certainly was a reduction in both in the Hydrus group. So if you look at the bar chart on the left, it shows the eyes with a percentage, 20% reduction in intraocular pressure compared to baseline at year 1 and year 2. And again, the dark blue curves are the Hydrus group, the gray bars are the Phaco alone group, and the Hydrus group seems to do way better than the Phaco alone group. If you just would look at just drop in intraocular pressure, the average drop in diurnal, again, at 12 months, nearly an 8.5 millimeter drop in intraocular pressure in the Hydrus group as compared to 6.3 in the Phaco alone group. So how do you put an Hydrus in? Do you put an eye stent in? Should I do a goniotomy? Should I do a GAD? How do we know? There's very little out there in literature prospectively comparing any of these procedures. But I think that's what we're going to see in the next 5 years come out. The COMPARE trial was one of the first trials that came out that essentially compared a standalone Hydrus, no Phaco, with a standalone iStent inject. We put 2 stents. And again, the comparison was continued for a period of 12 months. They recruited about 152 patients. The Hydrus seemed to be way better than the iStent inject group at 12 months in terms of reduction in intraocular pressure. So if you look at 0 meds, 1 med, 2 meds, 3 meds, the Hydrus group had the largest number of patients who were medication-free at 12 months as compared to the iStent group. So based on this, if you truly want to get a patient off medications, especially if they're on more than one medication, you might want to consider the Hydrus or just putting an iStent in the eye. How do trabecular meshwork destructive procedures compare in all of this? So the GAT procedure was, we invented in Dallas about 2012. Essentially, it's one of the most cost-effective mixed procedures because you can get into Schlemm's canal for 360 degrees just using a 6-O-proline suture, which is blunted at one end. But you do require good corneal clarity, and you do require a little experience in working in the angle because you can actually create a lot of cyclodialysis clefts if you're not careful where you do insert the suture or the catheter. But if you look at the meta-analysis of GAT studies, most of them show that the mean decrease in intraocular pressure is close to 10 millimeters of mercury. You reduce about 2 medications. The success rate is about 60%. Now you might say, what's 60%? I get better rates with the trabeculectomy. But actually, if you look across the board with trabeculectomy studies, even 5-year, 10-year, 15-year data, the success rate is about 60 to 70%, even some with medications. So the surgical success rate is about the same. The advantage here is you still can do a trabeculectomy. The only significant side effect is hyphema, which is transient, lasts for the first few weeks, and then goes away. So if you look at a 24-hour follow-up from the Grover group, it shows that in about 200 patients in POAG, again, the decrease in intraocular pressure is about 10. Somehow secondary angle closure eyes, which secondary open angle eyes seem to do a whole lot better as compared to just POAG, especially steroid-induced glaucomas, uveitic glaucomas, seem to do a lot better with reduction in intraocular pressure from baseline with a gap procedure. The Cohook dual blade was introduced about 4 to 5 years later. It's a pretty elegant blade with a sharp tip that goes into trabecular meshwork. It has these 2 ramps on either side to elevate the trabecular meshwork. And as you pass it along, it does a beautiful job of cutting. So if you look at this is the cleft that you're going to create when you release the trabecular meshwork, and that's what you're looking for. So a short-term study showed that the reduction of intraocular pressure about 5 millimeters at 6 months, and it reduces medication use by about 1 medicine compared to pre-op. So if you look at Cyril's study at about a year, looking at retrospective analysis of patients undergoing the Cahook blade with the phaco, with a pre-op of 25.5 and a pre-op mean of 2.3 meds, you've got nearly a 50% reduction in intraocular pressure. The IOP reduced by about 12.3 from 25.5. You're reducing about 2 to 2.5 medications. And about 100% of these patients achieved a greater than 20% reduction in intraocular pressure. And that's why we feel this is a very ideal procedure for somebody with mild to moderate glaucoma, where you really don't need a 30 to 50% reduction in intraocular pressure. And you can get away without a filtering surgery. If you look at phaco KDB with the phaco iStent, again, another prospective randomized trial, small group, 164 patients, both lowered IOP and both lowered the need for meds. However, significantly more Cahook patients achieved a target of greater than 20% intraocular pressure reduction or greater than 1 medication reduction at month 12. So let's take a case scenario. 73-year-old woman, open angles, pachymetry of 523, 535, intraocular pressures are elevated, and she has a family history of glaucoma. So essentially, you have a patient here with high IOP, thin CCT, positive family history, on 2 medications, which she's tolerating very well. Intraocular pressure is controlled. She has a significant cataract with pre-perimetric glaucoma. What are your options? You can add more medicine, certainly. You can add SLT, or you can consider surgery, and the choices between medicine and laser, the previous speakers have alluded to. So my recommendation here would highly be a MIGS surgery in combination with phaco, because she does have a visually significant cataract, and that's what sways your decision right there. But what about adding medication? What happens if you add a 3rd medication to somebody already on 2, or a 4th medication to somebody already on 3? Your success rates or your therapeutic index of success is dismal. By about 6 months, over 2/3 of your patients have already failed the medications, either due to just lack of effectivity in reducing intraocular pressure or due to a side effect profile. And when you add a 4th, it's even worse. So this multi-drug therapy that we keep adding 1 over 2 to over 3 or 4 really is to satisfy your soul. You're creating more conjunctival toxicity over a period of time, and a patient struggles to put in 1 or 2 drops a day. So if you ask yourself what you would want, I would say I would want to use 1 medicine or laser, or if I really need to use more than 2 medicines, please consider surgery in my office. So here is a 61-year-old white female. 7 years ago, she presented me. Initial pressures were 23 and 27. Fairly average to thin corneas, 546, 550. She has an early field defect in the right and a dense field defect in the left. She already had an SLT in the left eye in 2018. She has very good vision in both eyes centrally. Pressures are 14 and 21. And she's on 3 medications, a combination of brimonidine, brinzolamide, and bimetoprost or Lumigan. So this is a structure-function correlation. Essentially, the right eye is in better shape, but not normal. There's a small inferior field defect there that's probably getting worse. The left definitely has a significant visual field defect, and she shows up with a disc hemorrhage. So essentially, I have a documented progression of the left eye on fields, history of disc hemes, and the intraocular pressure is above target. She's already undergone SLT. In the right eye, you have somebody who's possibly the field is decreasing inferiorly with some fluctuation in intraocular pressure. So options as any other glaucoma patient is adding medicine versus surgery. In terms of surgery, we consider MIGS, subconjunctival MIGS, or a TRAB, like I showed you in the first flow chart. But can a case really be made for MIGS in this case? So you've got to discuss the pros and cons of surgical interventions and guide the patient to your best possible response. So if you consider the left eye, I would say the MIGS choice is debatable. It depends on an individual patient and whether the patient knows for sure that they are willing to undergo future surgery if this one fails. But filtering surgery seems to be the more prudent choice. And again, you can argue between a subconjunctival MIGS like a PreserFlow versus a traditional filter. Whereas in the right eye, you definitely need to consider SLT as a bare minimum. Adding more medication is not going to help. And I think a good case can be made for MIGS surgery in this patient. So where are we right now? So at this juncture, we really do not have a readable, available outcome marker or device that can actually tell us what the flow through the aqueous channels are. So it's a hit and a miss, right? So we do patients, we do a goniotomy, ultimately monitor intraocular pressure. If it works, it works. If it doesn't work, it doesn't work. Okay? If it doesn't work, we move on. We add medicine, we delay. Now, in a country like India, that becomes a big challenge because patients are paying a fat sum of money for some of these devices, some of these cases. So what assurance can you give this patient? We really, truly don't have much other than the prospective studies or what we have the evidence in literature. But in a given patient, we do not know whether this procedure is going to work or not. You do have the challenge of patients coming to you with multiple medications, and treatment-naive patients always seem to do better with whatever you do on them. So aqueous angiography, in my opinion, is what we need before we actually go forward with any more mixed devices or any more innovations in this field. You want to visualize the aqueous humor outflow in real time. You can do it on a research basis right now by intracameral injection of ICG or fluorescein. You need a modified microscope that actually visualizes the fluorescence. And they essentially said there's no approved FDA platform for this as yet. So what we discovered with aqueous angiography is that the flow around the carotid channels is not uniform. It's definitely not 360. There are high flow rates and the low flow regions. The green arrows indicate the high flow regions. The red arrows indicate the low flow regions. So this actually challenges our assumption of circumferentially equal aqueous drainage. The outflow patterns can change over time. When you do mixed procedure, you can recruit channels that have been previously inactive. And the conventional pathway seems to have a reserve capacity. So we're learning more and more about this system, which we have not used for many, many years as we continue to work in the space. So the applications really are, you can do real-time image-guided MIGS. You can actually guide where you want to place your stent. Do I place it nasally? Do I place it 10 o'clock? Do I manage to sit in some other way that I can and contort myself and put the stent in some other way? How much of the angle should I open? 90, 180, 360? We can actually evaluate post-operative changes in outflow. This is our hope. And Alex Wong has been amazing and a leader in this, and I continue to support his work. And hopefully this will show some fruition in the future. So right now it's expensive, specialized equipment, increases your operative time. The interpretation of images are still evolving and currently not available clinically. So I'll conclude by saying that if a patient needs a very low intraocular pressure, close to 10 or sub 10 to prevent blindness, then it might be worth the risk of filtration surgery. But remember, once you filter somebody, there's a lifetime of bleb vigilance to ensure the bleb is working, there are no bleb leaks, and to try to avoid bleb-related endophthalmitis. However, most patients seem to do pretty well with postoperative IOP in the mid-teens on one medication, or maybe 1.5 medication that's truly achievable with current mixed procedures. You definitely should consider angle surgery for your adult open angle patients, and as literature evolves, even for your primary angle closure glaucoma patients. So thank you very much for this. Thank you. Sure.
Thanks, Arvind.
Sure.